I first got introduced to this topic with Dr. Bedi in fellowship. We were doing lateral procedures, and he said, put the screws in lateral position. I looked at him, what the heck are you talking about? How do we do that? So it got me thinking throughout my career how to make things better in workflow and OR efficiency, and single precision surgery has kind of taken off in my practice, and so it's really shown to be quite a time saver. So I don't have any disclosures that are relevant to this talk. So what we're talking about, lateral interbody fusion, which is truly an MIS technique, allows access to the disc space. Either you go trans-psoas, anti-psoas, whatever. It's going to the retroperitoneal space and accessing the disc space, X-lift, L-lift, O-lift, whatever you want to call it. So the issue becomes, with workflow and patient positioning, we want to try to obtain a circumferential fusion, doing the lateral, approaching the interbody through a lateral position, but to put screws traditionally, we'd have to flip the patient over, and this presents a workflow problem. And so, when you're especially trying to put supplemental fixation posteriorly, how can we make this better and more fluid in the OR? So typically, workflow in the OR setup is 30 minutes. If you want to perform an A-lift, that's another procedure. Then you have to reposition, 45-minute flip to do an X-lift and complete the X-lift, another flip, fixation. So this adds up. I mean, this whole workflow right here is about 300 minutes, 5 hours in surgery. What if we can eliminate a couple steps to make things more efficient in the OR? So, eliminating those steps would pretty much streamline the OR workflow process. So there's also inherent risks of prone positioning. As well documented, we know postoperative vision loss can happen through posterior ischemic optic neuropathy, central retinal artery occlusion, cortical blindness, and also with the prone positioning, that it also has effects on the stroke volume and cardiac index. It raises the central venous pressure and can induce hypotension. So when you're planning a major spine surgery and you're anticipating blood loss, doing the prone positioning will further exacerbate hypovolemia, and that can be a very challenging problem to address. And so I present this paper out of Duke from Dr. Blizzard and Dr. Thomas, talking about MIS single position lateral and oblique lumbar interbody fusion with bilateral pedicle screw position. They looked at 72 patients, and they examined about 300 screws. They averaged about 6 minutes per screw posteriorly with a 95% accuracy. Interestingly, the upside pedicle, so when you're in the lateral position, the upside pedicle seemed to have a little bit more complication rate in terms of medial breach, but this wasn't statistically significant. And in looking at the quality of the pedicle screw placement, they only had 11 grade A breaches, so less than 2 millimeters, which were clinically insignificant. They had to revise actually 2 screws for malpositioning. So total operative time is promising in the fact that it's 87 minutes to do a circumferential fusion, which definitely enhances OR workflow and decreases anesthesia times. Another study out of Stanford looked at single position versus lateral, then prone positioning, so single position versus dual position. Looking at it, the dual position versus single position added 44 extra minutes in terms of operative time, which is significant if you're trying to get through your day. 42 single position and 24 dual position patients were analyzed. No differences were observed in perioperative outcomes, and lordosis wasn't different between the pre-op and post-op X-ray parameters. And actually using unilateral screws versus bilateral screws saved 26 minutes of additional OR time. So I present to you a case that I recently did, an 82-year-old male with severe pain down his right anterior thigh, and he had some quadricep weakness. He had a previous L3-4 laminectomy a year prior to seeing me. And you can see here, he has post-laminectomy collapse at that L3-4 level with this foraminal disc protrusion causing him severe radicular symptoms. He has a prior laminectomy defect as well posteriorly. So looking at the x-rays, you can see the asymmetric collapse, the spondylolisthesis he's acquired since the surgery. And the MRI image here doesn't show any significant central narrowing, just mainly L-foraminal stenosis. So I thought he would be a good candidate to do the lateral interbody fusion. So basically he has post-laminectomy collapse with L3-4 with severe right foraminal narrowing, L3 radiculopathy. So we offered him single position lateral interbody with posterior instrumentation. You can see here I'm putting the screws in the lateral position. It's a little bit of a it plays with your mind a little bit because you're obviously opposite. I did this under fluoro because his pedicle anatomy allowed for it, and up is down, down is up. So you really have to kind of train your brain to think in 3D and really convert your 3D spatial orientation. So overall, I did unilateral pedicle screws. Operative time was 82 minutes with minimal blood loss. He was discharged on post-op day 2, complete resolution of his symptoms after 6 months. So takeaway points, the prone position does carry inherent risks. There is, in healthcare now a trend towards value-based in terms of cost savings. And, looking at this, it's important for us as surgeons to really streamline our workflow patterns in order to decrease OR times and still maintain safety and enhancing patient outcomes. So I know we're a little over time, so I just want to wrap it up.
Thank you, Dr. Bedi, for being the only speaker on time.